Febrile seizure is a common neurological problem in children. It is seen in 2 to 4% of children under 5 years of age. We know height of fever, infections such as human herpes virus 6, influenza A virus, certain immunizations such as DTaP and MMR can increase the risk of febrile seizure. 10 to 20% of the parents' siblings also have a genetic susceptibility for febrile seizure. Interesting associations are known with iron insufficiency, allergic rhinitis, and tics. Most of the febrile seizures are simple febrile seizures with unintended consequences. There are complex febrile seizures and febrile status epilepticus. The risk of future epilepsy is as common as the general population. The febrile seizure can mimic shaking chills, meningitis, or genetic epilepsy with febrile seizures. Most of the diagnostic evaluation is history and physical examination and reassurance to the primary caretaker. This journal club topic is acetaminophen and febrile seizure recurrences during the same febrile episode by Murata et al. Published in Pediatrics 2018. In clinical practice, we reassure parents and do not send kids on preventive medicine most of the time in febrile seizure. Current knowledge about use of anti-epileptics such as phenobarbital and valproic acid has some role in prevention, but the risk outweighs the benefit due to the side effects of the anti-epileptic drugs. There is a good evidence for intermittent diazepam use for 2 days following a febrile illness to prevent recurrent febrile seizure, with the caveat that it is very sedative and may mask signs of meningitis. Again, there is a discomfort with the risk and benefit in using diazepam in current practice. Use of antipyretics is studied scarcely. Schneiderman's article is a randomized trial with the usual use of acetaminophen with the sporadic use, and it showed no difference. Unfortunately, the dose used in the sporadic control was a higher dose. Followed by that, a few studies and one meta-analysis has shown that the use of antipyretics has not reduced the risk of subsequent febrile seizure. Let's try to formulate a question. Before that, let's try to classify the question here. We can classify healthcare research questions into 8 categories: prevention, screening, diagnostic accuracy, prognosis, incidence, prevalence, etiology, and therapy. Also, therapy, prevention, screening, diagnostic accuracy groups can study harm. Let's practice this classification in context of a febrile seizure. Prevention. How can febrile seizure be prevented? Screening. Will detecting febrile seizure early in the symptoms make a difference in children's health? Diagnostic accuracy. How good is EEG in detecting febrile seizure? Prognosis. What is the likely outcome of febrile seizure? Incidence. What proportion of children have newly diagnosed febrile seizure each year? Prevalence. What proportion of children are currently living with febrile seizure. Etiology: what causes febrile seizure? Therapy: what should be done to treat febrile seizure? Harm: will there be any negative effects for treating or preventing febrile seizure? Now you get it. Once you figure out the classification of the question, in this case, how can we prevent febrile seizure recurrence in this episode? We can start thinking what kind of study will provide the best evidence, and you already knew this answer: randomized controlled trials. Now we understand how to frame a research question, how to classify different types of research question. Let's focus on the framing part. You are familiar with PICO, the acronym for Patient, Intervention, Comparison, Outcome. When you look at this article, look at the relevant population you are going to read or study. Did they define the study clearly, which means the febrile seizure with all the components to it? Pay attention to the type of seizure they have mentioned in this paper. Have they focused on the demographics of age, race, sex? Is it in the community setting, hospital setting, or an outpatient setting? What about intervention? Do they have a description of timing of the treatment, where it is started, who is supervising it, how they are administering the medication, is there a dose, and the duration of treatment, etc. Comparator. Comparison in this case is not giving the acetaminophen after the first febrile episode seizure. There is no discussion why placebo was not given, the rational part of it. I guess they are going down the route of no treatment versus treatment with acetaminophen, or it can be a standard of care and let the parents decide should they give Tylenol, i.e. acetaminophen, or not in the control. What is the outcome or the condition of interest? Do they have a criteria for defining outcome? Was that a clinically important outcome, such as having no febrile seizure in the first 24 hours? Or was it important to the patient or the family that they felt that they don't have to deal with another episode of febrile seizure, and it is an important outcome to the patient? Now that we have walked through classification and understanding the PICO format for the question, let's try to do a well-constructed clinical question. Great job. Now you have formulated the PICO question. I want you to understand that prevention studies are designed to examine causal association between a preventive intervention and failure to develop an outcome. And these questions are usually analytic, not descriptive. If you paid attention to the aim of this article, there was a second question about safety of using acetaminophen in febrile children for preventing recurrence. So in summary, we understand whether the study design was used for therapy, harm, prevention, screening, or diagnostic accuracy, and then formulate a PICO question formulate. For this prevention study, we all understand the randomized control study is the best evidence, and if we are lucky, we may find one day many similar randomized control trial for the same question and would be able to do a systematic review and a meta-analysis. Just a quick review on the choice of studies. One can choose an observational or an experimental study. Observational studies do not control either the exposure or the intervention. For example, the acetaminophen here. And some examples you already know are case reports, case series, cross-sectional studies, case control studies, and cohort studies. On the other hand, experimental studies, the investigators control the administration of this test intervention to the study participant, and it serves the purpose to evaluate this intervention is effective or not. The idea of a randomized control trial is that groups with and without the intervention should be balanced on both the known and unknown characteristics associated with the prognosis. Hence, only difference between the intervention group is the intervention itself, and the effect of the intervention can be isolated. Now that you know this article is on randomized control trial, pay a little attention to how the allocation of subjects were done. Was the randomization technique appropriately explained? Did they have a stratification which will help strengthen the study? And how is the outcome defined? Did they power the study with enough sample size for the outcome? Were the prognostic profile at the entry were balanced between the groups that will not interfere with the outcome? Was there any intention to treat analysis performed? Was there any place for confounding, a chance in play that the results are not truly significant, any other bias, including selection bias, observation bias, etc. Now that you have asked a research question with a classification and formulate a PICO question and some idea of a randomized clinical trial to critically appraise this article and use a tool as a CASP tool or a Consort 2010 checklist is also an alternative. And this talk is not an exhaustive exercise, but just an introduction to approach this journal club. You would realize most articles will not have enough information to analyze, but we do our best to make a meaningful decision. Thank you for listening.